Hello, this presentation will introduce you to trauma specialization in the field of counseling. As someone who specializes in trauma myself, I have a strong bias toward the importance of counselors achieving, at a minimum, general competence in what it means to be trauma-informed. I hope this presentation will inspire you to pursue education outside of the graduate program to prepare you to recognize trauma in your clients. In 2015, a study was published through the World Mental Health Consortium. They surveyed over 68,000 people across 6 continents and 24 countries to determine the level of experience of traumatic events. They found that over 70% of those surveyed had experienced at least one traumatic event, with over 30% reporting having experienced 4 or more. When we hear the word trauma, we may think of crisis and disasters such as floods, hurricanes, or war, or interpersonal violence such as sexual assault, physical assault, homicide, or suicide. But there is another realm which we are all experiencing through the COVID-19 pandemic, and that is collective trauma and the global mental health crisis that continues to grow significantly as a result. In the Ben-Jay study, there were 5 types of traumatic events, which accounted for more than half of all exposures. These include witnessing death or serious injury, the unexpected death of a loved one, being mugged, being in a life-threatening automobile accident, experiencing a life-threatening illness or injury. While what was most illuminating about this study, however, was the finding that exposure to interpersonal violence had the strongest association with subsequent traumatic events. The ubiquitous nature of trauma highlights the need for counselors to understand its impact on those we serve. In the late 90s, a study was conducted to determine the relationship between adverse childhood experiences, or ACEs, and adult health risks. 17,000 adults were surveyed as to whether, during their childhood, they had experienced emotional, physical, or sexual abuse, emotional or physical neglect, loss of a parent through death or incarceration, or witnessing violent substance abuse or mental illness within their home. The number of yes responses was used as a measure of cumulative childhood stress. The study, and many subsequent studies, have concluded that early life stressors cause long-term changes in multiple brain and bodily circuits, resulting in a variety of physical and mental health challenges throughout life. As few as one yes response effectively alters an individual's risk for lifetime health problems. There is a proportionate increase in risk with higher ACEs scores. In the original Adverse Childhood Experiences study, 64% of participants reported at least one ACE, while 22% reported 3 or more ACEs. In 2013, Finkelhor et al. Asserted that the ACEs omitted certain experiences judged by developmental researchers to be significant predictors of long-term health and well-being. So they created the ACEs Revised, which includes an additional 4 items: peer rejection, exposure to violence outside the family, low socioeconomic status, and poor academic performance. Repeated research efforts continue to provide evidence that adverse childhood experiences can lead to depression, anxiety, post-traumatic stress disorder, substance abuse, sleep disorders, autoimmune disorders, and inconsistent or absent health care, which leads to other health conditions later. Many of these individuals find their way to counseling. Therefore, it is reasonable to assume that the percentage of people who seek treatment that have an adverse childhood experience in their past is higher than the general population. Again, this highlights the need to be sufficiently trauma-informed so you can recognize where trauma is present, even if not stated as the reason for seeking counseling. Being trauma-informed describes a particular lens through which you perceive your clients. A trauma-informed counselor understands the long-term effects of trauma on the individual, families, and the community. They recognize the signs of historical trauma and view its manifestation not as symptoms or pathology, but as coping mechanisms used to deal with the emotional and psychological stress their clients have experienced. The trauma-informed counselor does not ask the question, "What is wrong with you?" but rather, "What happened to you?" The trauma-informed counselor recognizes the systemic and institutional issues which both cause and exacerbate trauma, and how the very systems designed to protect people, like the foster care system or criminal justice system, are often the source of trauma and re-victimization. The trauma-informed counselor recognizes the impact that power and privilege have on the infliction and perpetuation of traumatic experiences. I believe that counselors are in a unique position, as outlined in our Code of Ethics, to address the public health issue that widespread trauma creates. The professional counselor's ethical mandate is to promote respect for human dignity and diversity and to promote social justice. For those of you on the clinical track or dual school clinical track, you will take the Diagnosis and Case Conceptualization course, and the focus of this class is on the Diagnostic and Statistical Manual, or DSM. The DSM is published by the American Psychiatric Association. There is much debate on what value the DSM brings to our field that is beyond the scope of this presentation, but it is a necessary evil in that managed care practice requires that we provide a diagnosis for clients, and the DSM provides guidelines and a common language for doing so. The most recent iteration of the DSM was published in 2013 and is the 5th edition. The DSM-5 includes the category Trauma and Stressor-Related Disorders. Within this category is included post-traumatic stress disorder, acute stress disorder, and adjustment disorder. Each of these diagnoses requires the presence of an identifiable event or stressor, either experiencing or witnessing, which results in the presence of intrusion symptoms, avoidance behavior, negative alteration of cognitions and behavior. What is not included in the DSM-5 is a category long ago deemed by trauma professionals as a necessary addition: complex PTSD. Complex PTSD is the result of chronic and cumulative traumatic experiences and conditions. There is not necessarily one specific event to point to or flashbacks had, but rather a general sense of trauma. Individuals with complex PTSD experience difficulties with emotional regulation. They may be over or under-reactive as appropriate to circumstances. There may be difficulties with consciousness. They may have memory loss or blanks for periods of their life. There's a sustained deterioration in their self-perception, and there's instability in relationship with others, and an overall change in one's worldview and meaning system. This graphic highlights the complexity of symptoms and presenting issues which extend beyond the simplistic PTSD diagnosis. This again draws attention to the importance of pursuing further education beyond the DSM's trauma-related diagnoses. This slide shows some of the issues clients may state as their presenting problem. These issues show up as diagnoses in the DSM-5. However, where complex trauma is present, these can all be merely symptoms of the underlying trauma. Trauma manifests in all of these ways: anxiety, depression, difficulties with relationships, whether that's family, friends, or romantic partners, abuse of alcohol, pot, and other substances, suicidal ideation or attempts, and a variety of forms of self-harm, including cutting. You can treat these various symptoms. However, addressing the underlying trauma will result in a more holistic recovery process. One of the fundamental principles of the ACA Code of Ethics is non-malfeasance, or to avoid doing harm to our clients. What are some of the ways that clients can be harmed by a counselor who is not trauma-informed? Misdiagnosis. You don't know what you don't know. You may see substance abuse or anxiety or self-harm and diagnose accordingly. A trauma-informed counselor will explore further. They will see the behavior as the client's solution to their problem rather than it being the problem itself. The diagnosis that I currently hear bantered about with far more regularity than its actual occurrence is borderline personality disorder. If you compare the description of complex PTSD with borderline personality disorder, you will see a remarkable similarity in symptoms. Sadly, borderline personality disorder is in the DSM, but complex PTSD is not. Any personality disorder, and especially this one, is a heavy label to place on an individual. Personality disordered individuals tend to be viewed with less patience and a negative prognosis, leaving those so labeled in a position of continued traumatization. Re-traumatization is another potential harm to clients. Viewing a relationship issue as a communication problem rather than recognizing the historical abuse or current abusive power dynamics present in the relationship. Such a client may go home and further acquiesce to their domineering partner, taking the blame for the relationship on themselves. A simplification of the source of a client's pain may exacerbate their symptoms. For example, if a client discloses a history of binging and purging, and the counselor responds with a cognitive behavioral therapy assessment and says, "So, you lack control," the client will not feel heard or understood and will likely experience significant shame and continued self-defeating behaviors. Lastly, the client may feel that counseling is futile. The therapist doesn't get it, so they discontinue counseling altogether. Clients are masters at dropping hints, sometimes not so subtly, of current or prior trauma or abuse. The untrained counselor may miss the hint, or worse yet, notice it but feel uncomfortable going there, so they redirect the session to another topic. I hear this often from my clients who are sexual abuse or assault survivors, that their previous counselor seemed to avoid the topics they most needed to discuss. Fortunately, these clients chose to try again with another counselor, but not everyone will. By now you may be thinking, okay, clearly this is important, so I'm sure we will be learning about this in our master's program. And the response to that is, well, not really. The Council for Accreditation of Counseling and Related Educational Programs does recognize the need for counselors to be trauma-informed, as evidenced by the mention of trauma throughout the CACREP standards. However, CACREP does not dictate the manner in which programs may choose to meet those standards, stating that program innovation is encouraged in meeting both the intent and spirit of the 2016 CACREP standards. Program faculty and reviewers should understand that counselor education programs can meet the accreditation requirements in a variety of ways. So, because there are already 60 required credits to earn a master's in counseling, this leaves little room, time, or funding to add extra courses. What most graduate counseling programs do to meet the intent and spirit of the standards is to infuse trauma education into already required courses. I have a couple of problems with this. Infusing often means a mention or a portion of a lecture which addresses trauma. The content and extent to which is in the hands of each individual professor and their choice of course development, which brings me to my second issue. Trauma-specific training does not appear anywhere in the CACREP doctoral program standards, so the very people developing the content to train counselors in trauma by infusing trauma education into their courses are often not themselves trauma trained. Again, we cannot fault the graduate programs. None of us want to spend even more time and money before getting licensed and out into the field where we can start helping others. But this is a reminder that your counseling degree is basically a starter kit. You will learn a little about a lot of things, and then you will go on to learn even more. In the rest of this presentation, I will share with you my thoughts on how you can become a trauma-informed counselor, beginning right now. You have available to you in Moodle the PowerPoint file with these slides, as there are many hyperlinks to websites and information. The Substance Abuse and Mental Health Services Administration has published a bulletin which outlines their guidance for a trauma-informed approach, encompassing all service levels, from individual to agency or institution to governmental and societal. Trauma prevention, like trauma itself, is a systemic issue which requires a systemic response. The state of Michigan has its own resource page on Building a Trauma-Informed Michigan through the Michigan Department of Health and Human Services. Educational material for both clinicians and clients, as well as training opportunities, are provided. In 2015, the American Psychological Association, in conjunction with a variety of mental health professionals, published the Guidelines on Trauma Competencies, which outlines the minimal knowledge, skills, and attitudes necessary for entry-level clinicians to provide competent trauma-informed services. The ACA, in 2018, issued a resolution stating the counseling profession's commitment to serving traumatized populations and accepting the APA's guidelines. To date, the American Counseling Association has not had a trauma division. That is in the process of changing. Thanks to the efforts of Drs. Smith, Mayfield, and Weber, the International Association for Resilience and Trauma Counseling, or IARTC, is about to be granted organization affiliate status by the ACA. IARTC promises to be a growing resource to counselors globally. There are two books which I consider seminal to the field of trauma counseling. The first, Trauma and Recovery, was written in 1992 by Dr. Judith Herman and provides a foundation for understanding trauma survivors and the growing field of trauma prevention, education, and treatment. Dr. Herman places trauma within the social and political context in which it thrives. It is Dr. Herman who introduced the concept of complex PTSD and has been advocating for its inclusion in the DSM for 3 decades. Joining her in advocating for recognition of complex trauma is Bessel van der Kolk. His book, The Body Keeps the Score, provides a comprehensive introduction to the neurobiology of trauma. Van der Kolk shows how trauma literally reshapes both body and brain, and he explores a wide range of treatment approaches. You will be learning about a variety of theories during the counseling program. I would like to highlight a few that provide a strong foundation for, and within which, trauma counseling fits well. Psychodynamic and developmental theories are all key to understanding the effects of trauma. The ACEs study we discussed earlier shows the importance of understanding clients' childhood and developmental phases, and therefore being able to recognize where clients lack experiences or have missed milestones. Emotionally focused therapy is humanistic and psychodynamic in its orientation, with a focus on the emotional consequences of prior wounds and how to heal those relationally. Internal family systems therapy, as titled, views the family of origin system as the source of suffering. Internal family systems focuses on parts, or the various aspects of self, that need to be integrated in order to become a healthy person. The parts offers a template for moving into an understanding of dissociative states from mild to more severe versions. Feminist multicultural theory is concerned with addressing oppression in all its forms, both individually and systemically. Feminist theory has its roots in gender equality, but it encompasses much more. Feminist multicultural theory addresses oppression in all its forms and within all marginalized populations, including racism, ageism, disability, gender, socioeconomic, ethnic, and religious minorities. Polyvagal theory offers a great primer on the neurobiology of trauma, how trauma interacts with the autonomic nervous system. Keeping in mind that the way a particular treatment becomes an approved evidence-based treatment is through research studies, and research studies can only be done with standardized treatment protocols and with defined populations and disorders. The disorders which are named and have agreed upon criteria are those that are included in the DSM. And as we said earlier, complex PTSD is not in the DSM. Therefore, there really is not any stated treatment protocol for complex trauma. Rather, the counselor uses a combination of various approaches and techniques to meet the client needs. That said, there are a few techniques that are in most trauma counselors' bag of tricks, which I've listed here. Mindfulness techniques and tools are an invaluable resource for any counselor. In EMDR, there is a phase called resourcing, which is basically the building of a skill set within the client which allows them to self-soothe and manage their own emotion regulation. Trauma-informed CBT is a structured program which is used with children and adolescents. It is designed to be delivered over the course of 12 weekly sessions. Cognitive processing therapy and acceptance and commitment therapy are two other CBT approaches that are effective with trauma clients. It's important to keep in mind that often the techniques are not used within the strict protocol as designed, but rather the counselor uses their clinical judgment to weave various components into their overall treatment plan. Lastly, according to Dr. Bessel van der Kolk, anyone who works with traumatized populations should be trained in EMDR, eye movement desensitization reprocessing. Some of these trainings are both costly and time-consuming. I recommend that if you are interested in learning any of these, that you go straight to the original source for training, rather than a diluted version through PESI or other continuing education organizations. Up to this point, I have been discussing trauma counseling from a general perspective. Beyond knowing general information about trauma and its aftermath and recovery, most trauma counselors pursue further expertise in a specific population. For me, it is survivors of sexual assault, sexual abuse, and domestic violence. I did my counseling internship at Haven, which is a sexual assault and domestic violence nonprofit agency. Other specialty areas are crisis and disaster response, suicide, homicide survivors, racial violence, military or law enforcement. And now, with the thriving pandemic, we've acknowledged a new group of traumatized people, those frontline workers who are trying to keep up with the rising medical needs of those with the virus. To pursue training within a specific population, it is wise to turn to the agencies who serve that population. For instance, if you are interested in working with the military, you would pursue internship and further training through the Veterans Association. At the very least, you would inquire as to what treatment methods and techniques are currently approved for the population you wish to serve. Speaking of frontline workers, let's revisit the concept of compassion fatigue that we discussed in the last module under Counselor Wellness. We described compassion fatigue, separate from burnout, as a phenomenon that affects all healthcare workers and caregivers at some point. Compassion fatigue is a profound mental and emotional exhaustion, which erodes the very core of us as counselors. We lose our capacity for empathy, hope, compassion, and presence. This results in feelings of guilt, resentment, and irritability, a lack of interest in our work, and the potential for errors caused by distraction or forgetfulness. There is a level of stress reaction that is beyond compassion fatigue, and that is known alternately as secondary or vicarious traumatization. Secondary traumatization occurs when the stories we hear from our clients are absorbed by us in a way where we are also traumatized by the details, images, and experiences they've shared, even though we didn't experience them ourselves. Countertransference may occur when our own trauma experiences are triggered by exposure to our client's trauma. Repeated exposures to others' trauma and the triggered emotions that result accumulate, and we experience secondary traumatization with symptoms very much like those of PTSD or complex PTSD. Most notably, secondary traumatization causes a profound shift in the counselor's worldview. Fundamental beliefs about the world are altered or even irreparably damaged. Laura Vandernoot Lipsky wrote a fantastic book about secondary traumatization called Trauma Stewardship, and I have provided a link to a 19-minute TED Talk called Beyond the Cliff that Vandernoot Lipsky presented, and it's a humorous look at how our jobs affect us, if not a little too on the nose. Lastly, I would like to provide you with some further resources. Probably the most widespread active trauma-related organization is the International Society for Traumatic Stress Studies, which, similar to ACA, has a variety of divisions and communities within its umbrella, which help you focus on your specific areas of interest. You can become certified generally as a clinical trauma therapist through the International Trauma Training Institute. You can also become certified in a variety of trauma-specific techniques, such as trauma-focused CBT, cognitive processing therapy, acceptance and commitment therapy, and eye movement desensitization and reprocessing. I have included links to a few of the heavy hitters in trauma work, each of whom provide various training opportunities. Janina Fisher specializes in attachment work and dissociation. Peter Levine has expertise in somatic healing and is the author of the book Waking the Tiger. Ariel Schwartz is also a somatic therapist, along with play therapy and resilience-informed therapy. And Stephen Porges is the father of polyvagal theory. I hope this presentation created an awareness of the importance of becoming a trauma-informed counselor and sparked your interest to learn more. Thank you for watching and listening, and wishing you all the best.